Well, Julian, thank you to you and the organizing committee for giving me a chance to share some of this work. So I'm going to talk today about kind of changes over the last decade in how we understand tumors in this very specific group of patients in this time of transition from adolescence to young adulthood. And some of you may see these patients in a pediatric setting and others in an adult setting. But I think we've learned they really represent a very different group, and one for which I'm going to riff off of Annalise's talk earlier, where we can really think about opportunities to abandon what we consider our standard of care for patients with glioma. There are many more opportunities here. So like Zach, I'm a history guy, and our world really in terms of glioma biology started here with Cushing, Bailey, and Eisenhardt. And you'll recognize this figure from 1928, where even then they identified the fact that morphology correlated with behavior. So there was some inference that could be made about biology based on what we were seeing through the microscope. And this remained the paradigm for how we thought about these tumors for 50 years. And I'll argue that that really only began to change kind of at the turn of the century as we had leaders like Greg Cairncross and Bob Jenkins who started to show us that there were elements in these histological entities that actually told us these are different diseases. And in particular, Greg and Bob identified that patients who had tumors with 1p and 19q loss, so chromosomal events, they had favorable outcomes, both in terms of the natural history of the cancer that they had and in the response that their tumors had to our available therapies. And this changed even more radically early on in the century when the group led by Daryl Bigner from Duke showed us that tumors that harbored mutations in the IDH genes were really radically different. And in fact, now we know that the path to gliomagenesis, when it occurs through IDH mutation, really leads us to a different tumor than when it occurs outside of that setting, even if what we see under the microscope looks the same. So, I think it's worth stepping back for a moment. This is 1928 to 2004. I think oftentimes we feel like we're not making progress. This is actually quite radical evolution. So this is what things look like if I were to give a talk to our medical students in 2016. I could show them this and say, this is what the world of gliomas looks like. This is from the 2021 WHO guidelines, and we can see the real change that's occurred is the fact that we've understood now that we learn more from the molecular biology of these tumors than we necessarily do from the way they look histopathologically. And as you know now, our whole schema for thinking about these tumors is radically dependent on molecular biology. Now, with 2021, one of the dramatic changes that occurred, and that many of you will know, is that now we think of diffuse gliomas as coming in two different flavors. That there are adult-type diffuse gliomas and pediatric-type gliomas. And fundamentally, one of the great differences between the two is that many of these diseases that we see in our younger patients, they're driven by a particular mutation. And that paradigm has changed a little bit since 2021 because of indigo. We now think of IDH in that same manner. But the multiple different mutational schema that we see in adult glioblastoma, that pathway to oncogenesis is quite different in our younger patients. So that idea of having pediatric and adult type gliomas, it suggests that there's this radical barrier. And our tumors don't know that our patients turn 18, right? In Toronto, if you're under 18, you get your care at Sick Kids. You turn 18, it's like leaving Hogwarts, right? You're cast off into the adult world. But our tumors don't know that. And if we look at the incidence of these two different types, pediatric and adult type gliomas in our patients, you can see it's on a spectrum, as you'd expect. The pediatric type tumors are enriched in our younger patients, the adult type in our older patients, but there is a spectrum. And it leads to the fact that we see adult type glioblastomas in 12-year-olds. We see BRAF mutant diffuse gliomas in 50-year-olds. So I'm going to focus, though, on this group, these adolescent and young adult patients. And on that biological track that I just showed you, you can see they really sit at that spectrum, where these are patients who have incident of both pediatric and adult type brain tumors. And this is a particularly interesting group because they're at a point of remarkable social, economic transition. But I'm going to show you data over the next little while. This is also biologically a distinct group. So if you look at these patients, gliomas account for about a third of primary CNS tumors in this group. And 80% of those are malignant. So these are serious diseases that we're seeing in this group. And in fact, the most common cause of cancer-related death in adolescent and young adult people are CNS tumors. So AYA oncology is something that's been demarcated as a critical place for focus. So it's a subgroup that's historically suffered from poorer outcomes than younger and older patients. And not clear why. There's been a lot of thought of what could be the cause of that. Some of it might be that these are patients who have low participation in clinical trials, and so what we learn about how to treat these diseases isn't as applicable to this group. There may be differences in host and disease biology. These are teenagers, young adults. We may be suffering from delayed diagnosis in these patients. They really are dealing with unique psychosocial and economic issues. And again, because we don't have trials that focus on these patients, we lack standardized treatment approaches. And yet it's a group for whom benefits and survival are really substantial, right? These are young people who have a lot of life to live. And this is from the NIH, when sadly the NIH existed and meant something. There's a need for multidisciplinary programs that are dedicated to caring for AYA patients. So I'm going to tell, again, a decade-long story from Toronto that I hope has contributed to our understanding of this group. And my story starts with a breakfast that I was having with two colleagues of mine, Uri Tabori, who's a pediatric neuro-oncologist, and Cynthia Hawkins, who's a neuropathologist. And we were having breakfast in 2013 over the winter break. And all three of us asked, we do a shitty job with these patients. How do we do better? And the story I'm going to tell you really, there were three elements to it. Part of it was the science, part of it was the people, and then part of it was the platform. And I'll tell you about all of that. So I'm going to start with the science. And this was work driven by Julie Bennett, who at that time was a pediatric oncology fellow at Sick Kids, is now a staff at both our adult and pediatric sites. And she undertook a study to try to understand the molecular landscape of glioma in this patient group, AYA patients. And I'm going to move a little quickly through everything because my ticker keeps ticking. But we took archived tissue from these patients and put them through this sort of testing, really with the biased approach of saying, if we look, we're going to find that these patients have tumors with driver mutations. And you can see the makeup of the patient cohort that we had. This was about just shy of 500 patients from the Toronto system. And you can see the range in survival there from patients who had pediatric type low-grade glioma, who have very favorable outcomes, the patients who actually did worse, the ones with pediatric high-grade glioma and our adult patients with high-grade gliomas. But when we looked at that whole cohort, what we saw was that nearly 30% of these patients had tumors that had a driver mutation. And with the fact that we now have an agent that can target IDH, almost 80% of these patients had a targetable mutation. So I'll stop for just a second. 80% of these patients have a tumor with a targetable mutation. This is an idea that we're working on right now. If we look, and we have the luck of having patients with IDH mutant tumors from the age of 6 into their 50s, what we can see is that over time, these are essentially ticking time bombs. You can see them accumulate further mutational changes as time goes on. And it leads to this idea, as adult, I think most of us here are adult neurosurgeons. You know, we see these patients with high-grade BRAF mutant tumors, with aggressive or high-grade IDH mutant tumors. Our colleagues in the pediatric world, they see these same tumors, but with the change of delta T that brings them finally to us. In other words, these are tumors that longitudinally are biologically at a very different place when they are first present in our young patients, and that over time accumulate mechanistic additions that lead them to tumors that we have struggles trying to treat. And we're actually testing this idea in Toronto right now of tumor interception. So it's very typical. My colleague Peter Dirks would see a patient at the age of 12, presented with seizure, had a very small T2 flare hyperintense lesion that we presumed was likely a low-grade glioma, stable for years. Would follow that patient with surveillance imaging from the age of 12 to 18. She would graduate from sick kids, come to see me. I would follow her for a few years. There'd be a sudden change. Patient turns 24, now suddenly this tumor takes on a new growth pattern, and it becomes very clear quickly that this is a patient who needs intervention. I would intervene. They would have an IDH mutant glioma, low grade. But that low-grade glioma was there when that child was 12. And we're beginning now to test the idea, if Peter, rather than keeping that patient on surveillance at the age of 12, if he removes that tumor, where will she be when she's 25? And will she be in a better place than she would be having surgery with me at that time? This is going to take us decades to figure out. It is very interesting. I'll tell you, what we're learning is we see these lesions that are certainly abnormal. They possess IDH mutations. They don't have the other panoply of hits that we see in our older patients. Whether that'll make a difference clinically, we don't know. So again, for us, I think things change radically with these two trials. So Indigo, all of us know, and now think about the role of vorasidenib and other IDH inhibitors for treating our patients with IDH mutant tumors. This one may not be as well known to you if you're not in the pediatric world, but this was a trial run by Eric Buffet at Sick Kids and St. Jude's. Pediatric patients, MAP kinase activated low-grade glioma. These are patients who were treated at recurrence and randomized either to dual BRAF inhibitor therapy or standard chemoradiation. And what this trial found is that the patients treated with targeted therapy had longer progression-free survival and less need for a second intervention. So very much, as we now know for IDH mutant tumors, our patients who have BRAF mutant tumors, we should be seriously thinking about BRAF antagonist therapy for those patients. This is another group I want to point out. This is work led by Lojin Negam and Uri Tabori. This was looking at the role of mismatch repair deficiency in young patients with glioma. I think all of us have been disappointed by the lack of benefit for most of our trials using immunotherapy in patients with glioblastoma. They really undertook work to see what the role of primary mismatch repair deficiency is in younger patients with glioma. So you'll remember mismatch repair deficiency kind of comes in two large flavors. One is congenital mismatch repair deficiency, so Lynch syndrome, something we probably don't see as much. But the other, and this is surprising, is when we looked at our young patients with glioma, almost 8% of their tumors had somatic mismatch repair deficiency. And you'll remember mismatch repair deficiency leads to essentially hypermutator phenotype. Now, we see hypermutator phenotype after we treat any patients with temozolomide. Those patients are uniformly not responsive to ICI, to immunotherapy. What we found in these patients who have primary deficiency, so not treatment-induced, these patients do respond to ICI. So looking at these patients, you'll see these curves here that if I'll ask you to look at B, that blue line is survival of patients with high-grade glioma, IDH wild type, I'm sorry, mutant and wild type disease, you see there, with hypermutator status. These patients respond to immunotherapy. I don't know if you uniformly test for MMRD or for hypermutator status in young patients with glioma. It's something we've instituted now in Ontario. Again, it captures about 8% of patients. These are patients we no longer treat with chemoradiation. We treat these patients with immunotherapy. So the one group, frustratingly, that didn't do well for us with hypermutator status and with immunotherapy were patients with IDH mutation in this setting. And this is work by Anna Brandas, another colleague of mine from Sick Kids. He treated these patients instead with combination therapy with an ICI and an IDH inhibitor, in this case, isovordinib. And you can see the survival there in both the German group and our Toronto group. You can see when we treat these patients with combination therapy, again, these are IDH mutant tumors in patients who have mismatch repair deficiency, they have fantastic survival. And what I'm not showing here is the curve for survival using chemoradiation. These are patients who do terribly with temozolomide chemoradiation. So that's some of the science. I'm going to go quickly through here. In the end, people make things work. And for us in Toronto, we've been very lucky to have the infusion of these four young people. They've really driven this idea that we need to look at AYA patients as a unique subgroup. And I'll say there are some fortunes of being in a socialized healthcare system. One of them is that it allows you to have some element of top-down coordination. Each of our centers now has a pediatric team, has an adult team, and has a combined pediatric and adult team who take care of these AYA patients. This is our group here in Toronto. Julie Bennett's a pediatric-trained oncologist who focuses on AYA. Mary Jane Limfat is an adult-trained neuro-oncologist who again focuses on AYA. Derek Sang is a radiation oncologist, trained both in pediatric and adult. And Seth Klemons, again, dual-trained pediatric and adult. And this is the platform. So 2021, as you guys know, all of us go into hiding because of COVID. Miserable for all of us. What COVID normalized, I think, was the idea that we could meet in a virtual setting in a way that could be productive and meaningful. I think about that often because, so Canon is a transnational consortium that we have, stands for Canadian Adolescent and Young Adult Neuro-Oncology Network. We meet bi-weekly in a virtual forum. We started this in April of 2021. Originally, the idea was to just have centers in Ontario who would be involved. It expanded very rapidly to include essentially our 22 major sites in all of Canada. We meet every week essentially to go over cases. We focus on AYA, but again, it speaks, as I said earlier, we have 55-year-olds who have MAP kinase mutant high-grade gliomas, and we come together essentially as a group to review these molecular data and come up with treatment recommendations. So far, we've reviewed about 400 cases. This has also been a platform for us to start national clinical trials, and we're focusing on the AYA subgroup. This is what our meetings look like. Again, all of us will come together every week, essentially, and simply go over cases. So I wanted to finish with this. Annalise already spoke about this, that the future is here. So the pillars of our work with Canon really focus in 3 different realms. One is molecular oncology, right? If you're going to find these patients, if you're going to be able to identify them in ways that allow you to guide their therapy, it depends on having the molecular diagnostics platform necessary to be able to characterize these tumors appropriately. The second is clinical trials. Again, we need to learn from what it is that we do. That may mean having multiple iterative N-of-1 trials. And I think our ability to do this with AI is going to expand rapidly. But these cases that we see in our tumor board, we think of each one of them as being an opportunity for clinical learning. When I was a medical student, I got to go to a meeting in San Antonio and got to attend their breast cancer rounds. And huge forum, and they would quickly go through 400 patients at a single time. But the question asked in reviewing every one of their patients was, which clinical trial does this patient qualify for? And I think for all of us here, we've got to be asking that question continuously, right? We do not do enough in the neuro-oncology space. We need to do more. That means all of us need to think of every one of our patients as an opportunity not only to serve, but to learn. The third pillar for us is this, liquid biopsy. And we are using liquid biopsy extensively now. We are doing this through study of CSF, not through blood. We haven't found blood to be particularly effective. I do have a colleague who has published using methylation sequencing from blood as a way of monitoring treatment. I'll tell you that's extremely tedious and expensive, and I don't think can be translated into something that'll be wide-reaching. But CSF, either through Omaya or serial LP, I think is something that can be translated and that we've found very effective. I'm going to jump, if I can, I'm going to show you this real quick. This is a patient I took care of recently. This is a 23-year-old woman. She presented in 2016 with obstructive hydrocephalus. This is when she was a child. She underwent endoscopic third ventriculostomy and biopsy of a pineal lesion at Sick Kids. The path came back as a pineal cyst. In 2017, the lesion was noted to be growing, and so she was recommended towards second surgery to confirm diagnosis. She and her family were hesitant to undergo surgery. She came for a second opinion and actually underwent gamma knife radiosurgery at Pitt. Was well for many years until she presented in 2024 with headache and neck stiffness. And her imaging essentially showed profound leptomeningeal disease. She underwent biopsy, which showed pineoblastoma. It was placed into the subgroup 2 by methylation sequencing. She had no known germline predisposition. She underwent craniospinal irradiation using protons with concurrent VCR. and then had adjuvant chemotherapy, which she tolerated well. At the end of therapy, essentially, she had a complete radiographic response. So looked like she was cured. But we looked at lumbar CSF, and you can see the readout from her CSF. She still has tumor. So she still has tumor DNA in her CSF. So this, our hematology colleagues would call this minimal residual disease. So cancer that is still there, even though all our clinical indicators show otherwise. So she's going to undergo treatment using what we would normally treat our patients with at Salvage. I placed an Omaya about 4 months ago, and she's undergoing intrathecal etoposide and temozolomide. And our plan is to treat for 1 year or to stop earlier if we see clearance of her CSF. So I'll stop there. Julian, thanks again for giving me the additional time. I hope you guys found this valuable to see. I will end on this, that I think this frustration that Annalise spoke to, that all of us feel, that all we have is temozolomide radiation for these patients, even when we know temozolomide won't work. I think we are at the cusp of not having that limitation anymore. My hope is all of us are going to find the next 5 to 10 years in neuro-oncology to be really exciting and leave us with an opportunity to really offer our patients more.
Thank you, Sunit. Fantastic, motivating talk. For years, we thought that liquid biopsy was not going to be sensitive enough, right? Even CSF, but you have it as the center of your management scheme. How often is it not enough, and do you have to resort to tissue diagnosis?
Yeah, Julian, thank you. I will tell you there are limitations. So if we look at our own series and combine it with the series from the team at Memorial, CSF liquid biopsy is very good for patients with high-grade tumors. It's excellent for many of the pediatric tumors, ependymoma, germinoma. The approach that we use involves essentially looking for what we want to find. And what I mean by that is rather than doing something like whole genome expansion to look for template DNA, so we look very specifically at what we know are typical driver mutations in these tumors. And if you find a P53 mutation, you know that there's tumor there. It doesn't let you know what type of tumor it is, but you know that there's something there. If you find an IDH mutation, then you know for sure, right? So we sequence specifically for those targeted elements. It's not as effective in patients with low-grade glioma. We have about a 40% hit rate in those patients, and that's equable to our colleagues at MSK.
Good, great. Amin?
Yes. Fantastic talk. Thanks. Just really going over the evolution. One of the advantages that as Canadians you all have is related to the ability to get liquid biopsies. So in the U.S., for us to get insurance to cover a liquid biopsy, we're probably going to solve the Middle East as well as cancer before United will actually give us liquid biopsies in the U.S. And what you're describing, we're relying on you because you're looking for the needle in the haystack because you know it's there. The answer is going to be what's in the rest of the haystack, right? The SNR that'll come out with large multiparametric avatar-based AI systems is going to show you the other 400 targets that we don't know about today that we'll be able to simulate. We're not going to be able to help you with that because they won't pay for it. After you prove it, then they'll pay for it. So this is really, outstanding work, but we're really counting on you all to do this.
Thanks, Amit.
Sunit, somewhat related, I'm curious what your approach for testing for BRAF mutants is. Given the prevalence, we try to do non-canonical testing for
Yeah.
mutations in BRAF, but as Amin pointed out, it's not always paid for, and sometimes we'll even convince patients to pay out of pocket because of the prevalence of them. I'm curious what your approach to testing is, and then what the data on the response rate for non-canonical mutations to the existing inhibitors is.
Yeah. So we include BRAF V600E immunohistochemistry in our panel for all patients with glioma. So this is regardless of age, pediatric, adult. In patients under the age of 50, we also include panel testing for BRAF fusion and other common BRAF mutations. Part of the difficulty is we don't know how effective many of our treatments are in patients who have non-canonical MAP kinase activation, right? We don't have great data for that. Most of these data are from patients with V600E mutation. I think our BRAF inhibitor therapies are much more effective in the setting of low-grade tumors than in high-grade tumors. And it probably speaks to the fact that this was a driver mutation that, like IDH, becomes less important as the tumor evolves. That said, I think our standard of care for those patients, so if you come in with a BRAF MAP kinase activated glioblastoma, those patients do get temozolomide chemoradiation, but their adjuvant therapy includes BRAF inhibitor as well. And I think we'll slowly accumulate that data. I can say anecdotally, it seems to make a difference. The thing I can't speak to are those patients who would do better anyway. In other words, do they have biologically more favorable tumors?
Jim?
Yeah, Sunit, just a couple quick questions. Thanks for the talk. How rapidly does molecular information in tissue biopsies die or degrade? And then secondly, do you see us getting to serial biopsy longitudinally for patients rather than using the original diagnosis? And where are we in that? And obviously I ask, working with you and Dr. Rutka and many people in the audience around the Oncology Tissue Advisory Board that we were talking about, but I was just curious, where are we with those? And
Yeah, so Jim, great question. I mean, I think our diagnostic abilities depend completely on the fidelity of the tissue. And, I think to my own cases, right? You give the nurse a specimen and it sits there on the table for 15 minutes before it's finally, put in formalin or put in some sort of preservation buffer. It's probably less critical for DNA than it is for RNA. And we still manage to do quite well with some approaches towards looking at the protein level, even with that sort of degradation, right? Immunohistochemistry is fantastic. I think it depends really on kind of what sort of sequencing approach you want to take. And if you think about kind of discovery approaches, you need much better tissue fidelity than kind of our more targeted approaches where you know what you're looking for. But I think for discovery, getting the tissue in a place where it's preserved quickly is critical. The second question you had was serial biopsy. So there's a group of us who've now put out two white papers essentially speaking to this need for continued kind of interrogation of the tumor. And I think we know what we see at time 0 is not the same as what we see at time X, Y, Z, right? This is a process that's continually evolving, in part because of our treatments. It's the ethics of clinical trials requires us to be able to balance risk and possible benefit to patients. and to really have the idea of equipoise, right? That we have a trial because we don't know what the best answer is. And if you have a clinical trial outside of those auspices, it's not right. For our patients with glioblastoma, the solutions we have are just not enough. 5% of our patients now with our standard therapies live 5 years. It's a remarkable achievement compared to where we were, but it's not enough. None of us feels like this is enough, right? So I think what that means is, from a clinical trial perspective, thinking about trials where we would do serial analysis. These are risks that I think we should feel comfortable asking our patients to take because of the need to learn.
Thank
Yeah.
you. One more question, and then I think Amin has a comment.
This is a comment and question, but I think, the notion of who pays for some of these things, like the liquid biopsy. I think what you said in your talk, there was a point you made that every single time you evaluated a patient or a group of patients, you're looking to see what kind of clinical trials you could enroll them in. I think that's the secret. If you end up doing these kinds of high-cost technology events, they need to come through a protocol that is going to look at the data in a meaningful way. A one-off, thing is what insurance companies are not going to do. As part of a clinical trial, they're likely to do this. And I think the results will be not just sort of dollar investment returns, but outcomes, ROO versus ROI. And we need to demonstrate that.
Amin has
Yeah, just an ask, maybe. My partner, George Babustik's there, who's the chief of our neuro-oncology program. I think Zach's comment about BRAF pathways is really interesting. George would tell you this all goes back to repair sequences, which is what you define. Looking up, so 2 asks. One is, if we start targeting upstream from MGMT repair mechanisms, that's how we came up with BRAF, right, for cranio. There are a bunch of cyclical events that are upstream that are common, and George looks for them routinely. So that would be one ask, because we can't unless we self-fund. The second ask is, I think your SNR, it'd be curious to see your SNR if you start to look at CSF exosomal patterns, because you're asking a progenitor cell to slip through the blood-brain barrier, get out into the serum. Then you're trying to pick it up in the serum, right? So if you say that the SVC zone has a 1% event rate, you're asking that 1% to penetrate through the blood-brain barrier, get through the venous system, get back out, and then you're picking up 0.5%. Or you can pick up in the subarachnoid space through, and today, exosomal signaling is cheap through chip technology. So I wonder, since you have the resources, ironically, and we don't, it'd be fascinating to look at those 2 things.
Let's talk.
Thank you. Fantastic.